Race impacts many things related to medicine today, including diagnosis and treatment. Spirometry or pulmonary function testing helps diagnose lung conditions based on height, weight, age, sex, and race. In this tour, we will examine the history of race correction in spirometry. The thought that there was a biological difference between races can be traced back to the 1700s. In 1781, President Thomas Jefferson discussed his suspicion that the black race was inferior to the white race in his notes in the state of Virginia. Specifically related to pulmonary function, he suspected a difference in structure of the pulmonary apparatus, giving black people a thermoregulatory preference for heat. In 1846, English surgeon John Hutchinson was recognized for his studies with spirometry, noting differences between genders, but did not look at the association between race. In the same period, Samuel Cartwright, a physician and advocate for slavery, conducted his own research using a spirometer, finding a 20% difference in lung volumes between black and white people. He used this to justify slavery and the type of labor slaves were suited for. Cartwright's studies received support in 1869 when astronomer Benjamin Gould compared the lung volumes between white and black soldiers. He did not adjust for environmental or socioeconomic status. In 1974, researcher Charles Rossiter and physician Hans Will provided one of the first suggestions for a scaling factor of 13.2% for black people. While acknowledging that socioeconomic factors may have contributed, they felt that they were unimportant given the consistency with which finding of a large ethnic difference in lung function occurs. In 1994, the third National Health and Nutrition Examination Survey, or NHANES 3, was being completed and revealed a lower forced expiratory volume in 1 second, FEV1, and forced vital capacity, FVC, in African American patients. It was suggested that the difference in spirometry values could be due to body build, as African Americans were shown to have a smaller trunk to leg ratio. However, the observed difference remains poorly understood. There is some thought that childhood illness, nutrition, cumulative effect of social and environmental stressors, and epigenetics may cause a difference in leg length and chest size. The current spirometry reference values assume a 10 to 15% smaller lung capacity for African American patients and 4 to 6% smaller for Asian patients, as recommended by the American Thoracic Society. The most up-to-date guidelines are from 2019 and based on observations from the Global Lung Function Initiative. While pulmonary differences between ethnicities may exist, the environmental and social factors experienced by people of color are confounds to the assumption it is due to an innate process. Systemic inequalities throughout history have led to generational poverty and poor living conditions that continue to impact health today. Social determinants such as income, access to care, food deserts, pollution, education, population density, and the stress of racial discrimination are associated with negative health outcomes. We must also examine how these inequalities impact lung function and incorporate them into our evaluations. Having race-based correction factors invites the opportunity for bias and misclassification of diseases, leading to inadequate treatment and perpetuation of disparities. There is a need for re-examination of previous and current literature to see if race correction is necessary. To eliminate health disparities and increase equity, we must take action to abolish practices rooted in racism, increase awareness of our biases, and remove barriers to care that put our fellow human beings at risk. Thank you. Thank you.